Hello dear viewers, in continuation of this series on difficult to treat or the resistant organism, in this video I am going to discuss about resistant enterococci. In the last part of this video, you will get a chance to solve a few questions based on the given content in the presentation, so you understand presentation in the depth. Welcome to Essentials of Acute Care. I am Dr. Sunil Garg. Enterococcal species can cause a variety of infections including urinary tract infection, bacteremia, endocarditis and the meningitis. There are mainly two species, Enterococcus faecalis and Enterococcus faecium. While infections due to Enterococcus faecalis tend to be more virulent than infection due to faecium, the clinical isolate of faecalis tend to be considerably more susceptible to beta-lactam agent like ampicillin than clinical isolate of faecium. Another susceptibility trait that helps distinguish between these two species is that isolate of the faecalis are resistant to cunipristine dalfopristine antibiotic, while faecium isolate are usually susceptible to this antibiotic. In general, determining the clinical significance of the enterococcus recovered from a patient should be tailored to individual patient circumstances, since isolation of an enterococcus does not necessarily require targeted therapy. Enterococci can also be colonizer, such as in the respiratory specimen or in the urinary catheter, or part of a mixed infection, such as in the polymicrobial infection in the setting of the intra-abdominal surgery or traumatic wound, for which therapy is being administered for more virulent organism rather than the enterococcus. High-level penicillin resistance generally indicate that species as Enterococcus faecium. In the setting of infections due to such organism with high level penicillin or the ampicillin resistance, and bactericidal therapy is needed like in patients with the endocarditis, either vancomycin or teicoplanin or daptomycin in the dose of 8 to 10 mg per kg intravenously daily could be used with an aminoglycoside. In the presence of high level aminoglycoside resistance along with high level ampicillin resistance or there is concern for the nephrotoxicity exists, high dose daptomycin 10 to 12 mg per kg IV daily can be used in such patients. Here it is important to note that the dose of daptomycin is more than when it is given in combination with the aminoglycoside. If high level ampicillin or the penicillin resistance is due to beta lactamase production, ampicillin sulbactam may be used as cell wall active agent along with aminoglycoside. When using an aminoglycoside in combination with ampicillin to achieve synergistic bactericidal therapy like in the setting of endocarditis, the testing of enterococci should include high-level aminoglycoside resistance testing for both gentamicin and streptomycin. Since one agent may have activity even when the other does not, the cell wall active agent should only be combined with an aminoglycoside to which the organism is found to be synergism susceptible. It means when the combination is showing synergism. Other aminoglycosides should generally be avoided like mycin or tobramycin. It is very important to note that aminoglycoside should never be used alone as a therapy for the treatment of enterococcal infection. The combination of the beta-lactam therapy like the combination of ampicillin or the ceftriaxone is an option for the treatment of infective endocarditis due to Enterococcus faecalis with or without high-level aminoglycoside resistance. Vancomycin resistant E-faecium isolate often have concurrent high-level resistance to beta-lactam and aminoglycoside. So effectively they have resistance to all first-line agents. In contrast, vancomycin resistant E. faecalis are usually susceptible to penicillin and ampicillin. Therefore, the optimal approach for the treatment of enterococcal infection due to vancomycin resistant E. faecium is uncertain. The resistance profile of the VRE isolate should be evaluated carefully in conjunction with the infectious disease expertise when selecting appropriate therapy for such organism. The approach to treatment of such isolate should be assessed in each individual case. The newer agents like linezolid, daptomycin and tigecycline have activity against both vancomycin resistant E. faecalis and the E. faecium species. In the setting of invasive infections such as endocarditis, meningitis and bacteremia, and especially in the setting of valvulopathy and or critical illness, bactericidal therapy is warranted. In such cases, either combination of ampicillin or penicillin with aminoglycoside is given or dual beta-lactam therapy like combination of ampicillin plus ceftriaxone or cefotaxime is generally given. Antimicrobial therapy for enterococcal bacteremia is generally given in following situation: when the patient has two or more positive blood culture, or a single positive blood culture if it is accompanied by signs of sepsis, or a single positive blood culture together with a positive enterococcal culture from another usually sterile site. It is important to note that in general determining the clinical significance of an enterococcus recovered from a patient should be tailored to individual patient circumstances, since isolation of an enterococcus does not necessarily require targeted therapy, as it can be a colonizer, especially in urine and in the respiratory secretion. It can also grow in the polymicrobial flora, specifically in samples taken during intra-abdominal surgery or from the traumatic wound, where therapy is targeted usually towards more virulent organisms rather than the enterococcus. It is important to have consideration about which strain patient is growing, whether it is faecalis or the faecium species, as it has treatment implication. Other important considerations include whether infection is invasive or urinary. If patient has invasive infection, usually bactericidal therapy is preferred over bacteriostatic. It is also important whether patient has associated endocarditis or critical illness, as such patient will require combination therapy with bactericidal agents. And finally, look for the resistance to penicillin, ampicillin, vancomycin, high-level gentamicin, and streptomycin. Here are few questions for you to solve and discuss. You can pause the video to read the questions and write your answers in the comment section box for discussion. Thanks for watching this video and do not forget to subscribe to this channel. I will continue to present important updates regarding antibiotics and other topics related to critical care. Once again, thanks for watching this video.